I'm Director of Engagement and Change at Healthcare Improvement Scotland, and I want to start by very warmly welcoming you all to this webinar titled From Transactional to Relational, Bringing Heart and Humanity Back to Healthcare, and it's great to see you all joining us. Before I introduce our speakers, I need to do a little bit of housekeeping. So first of all, the webinar is being recorded, but the chat box will not be visible within the recording. The recording of the webinar will be shared on our website and with our distribution list. Secondly, we'll be switching cameras off and muting mics to help with sound and picture quality. You're very welcome to use the chat box throughout the webinar to share your questions and comments, and we'll pick those up during the question time slots. And finally, if you have any questions or experience any technical difficulties during the webinar, then please contact either Alison or Karis, who I'm sure will pop their email addresses in the chat. So turning to the content of today, I'm delighted that we're able to bring together two thought leaders and practitioners of careful, kind and person-centred health and care. Kindness is something I'm absolutely passionate about. Those of you who see me in person will know that Just Be Kind is what's on my lanyard I wear for my work pass. So I'm especially excited to be able to hear from Professor Victor Montori and Dr. Dominique Allwood, who have been at the forefront of the global movement to develop understanding and inspire a return to a more relational, more compassionate approach to healthcare. So to introduce our speakers in a little more detail, first of all, Dominique Allwood, who's Chief Medical Officer at UCL Partners. Her focus is on clinical engagement across the partnership and with Health Innovation Network clinical executives in her role as the network deputy. She's also leading work on learning systems and improving population health and inequalities through developing anchor institutions. She's an experienced medical leader and a consultant in public health medicine. She's worked extensively across healthcare for 18 years in leadership, management and advisory roles for provider and commissioner organisations, academic institutes, national bodies, management consultancy, charities and think tanks. And next month, she starts a new role, having just been appointed as the new Chief Executive Officer of Imperial College Health Partners. Turning now to Victor Montori, who is the Robert H. and Susan M. Rewald Professor of Medicine at the Mayo Clinic in Minnesota. As an endocrinologist, health service researcher and care activist, he's the author of more than 750 peer-reviewed publications and is among the most cited researchers in clinical medicine and in social science. He's a recognised expert in evidence-based medicine, shared decision-making and minimally disruptive healthcare. His work at the Mayo Clinic focuses on advancing person-centred care for patients with diabetes and other chronic conditions, and he's the author of the book Why We Revolt and is leading a patient revolution for care and careful and kind care for all. So a huge thank you to both of our world-class speakers for joining us today, and I'm delighted to hand it over to you both. Thank you very much.
Thanks so much, Claire, for such a generous introduction, and lovely to see you and so many people on the call, and also really delighted to be presenting with Victor, who's a colleague and a friend and a co-conspirator in a lot of this work, and much of what I'm going to talk about has been inspired by Victor. I'll let Victor come on and say hello, and then I'm going to kick us off with the first couple of slides, I think. So Victor, just in case you want to give a little wave as well, and a hello. He seems to be on mute, so maybe he's feeling shy.
Yeah, no, I'm feeling shy. I'm just, it's great to be here, and thanks for the introduction, and looking forward to dancing with you, Dominique.
Wow, that seems to be turning into some kind of nightclub. I'm not sure we're in the right place for that. So let me start with this question. I'm just going to pause. I'm not going to ask you to put anything in the chat or write anything down, but I just want you to think for a moment about why you chose a career or a job in healthcare. There are many of us on the call, some people working in more clinical patient-facing roles, others in more of the management and administration side, some in providers, some much more at arm's length from direct care. But whatever you are doing, you're on this call because you have an interest in healthcare, and many of you working in it. So when we ask this question of our students, of our trainees, we hear all sorts of inspiring stories about people wanting to help, wanting to care. Some people wanting to choose a career as a doctor, a nurse, a pharmacist, whatever it might be. And lots of people are already putting some nice things in the chat about wanting to do many of those things. Now, next slide, please. I had the privilege of taking some time to do an MBA recently, and I got to ask this question of many of my colleagues that I work for as part of one of my modules. And I said to them both, why did you choose a career in healthcare? But also I asked this question about what is the purpose of your work every day? And if we click through again, I think there's a statistic coming up. Over 70% of people that I talked to gave this answer, which is to get as many patients into the discharge lounge before 12 p.m. as possible. Now, of course, that's really important to keep patients moving around in our system and make sure that we deliver timely and effective care. But if this is really the purpose of what everyone's doing every day, both Victor and I feel very strongly that we're missing the point of why we're here, what we're here to do. So the premise of our talk starts with some of this bigger picture stuff about our purpose and mission, but it also will delve into as well what it feels like to be in care as a caregiver and a care receiver at the moment. And I'm going to in a moment hand over to Victor, but I just want to show you this piece of artwork that we both have become very familiar with from a piece of writing that we did for the BMJ Christmas edition. And you can see from the picture really what we're trying to sum up here about how healthcare feels to many of us at the moment, being on the receiving and the giving end. So Victor, I'm going to hand over to you, having set the scene as to some of the issues and some of the things we might be thinking about working towards to bring heart and humanity back into healthcare. I think you're on mute again. Hopefully Victor will be coming off mute. Oh, I'm not sure, Victor, if you can hear me, but you are, I think, on mute. Unless
Yes. I'm just trying to make this work. The controls have changed since last time I played with this, and
you're new. Okay.
Yeah, I'm new. Yes, thank you. Yes, and so in this conveyor belt, one of the things, one of the effects of that sort of flow, of that processing of people, is that patients are seen sometimes too fast by clinicians, sometimes simply reflected or represented by their test results. Or by a statistic being perhaps at the top tertile of the patients that have poor control of their diseases, or perhaps the biggest challenge of it all is the sense that I've reviewed the medical record, therefore I know this person. So all these effects, speed, representation by a piece of data, or the medical record standing for the patient, render the patient blurry, and the ability of the clinician to respond to the problematic situation of the patient much more difficult. This is now a better picture of the person that was in that initial blurry one, Maria Luisa, and she's in her home, and you can see her staring at her pill box, or a box filled with pills, if I may. And as you look at her expression, you can see that she seems lonely, tired, perhaps overwhelmed. But somehow, despite the blurry picture, healthcare has managed to prescribe these pills to Maria Luisa. And I think the reason we can do that is because we can see in Maria Luisa what are the systems, organs, and biological processes that are broken. And by responding to her biology, we're responding with these pills. But in doing so, we're caring for her as we would care for people like her, people with the same biology, with the same diagnosis. But that's not the job. The job in clinical practice is actually to respond to Maria Luisa's problem, to care for Maria Luisa. And for that, it's not enough to look at what is common about Maria Luisa with other people with the same diagnosis, but we also have to look at and see what is particular about Maria Luisa's situation. And we think of it as thinking both about her biology and her biography. And about her biography, we may want to be interested in her exposure to adverse childhood events leading to her chronic conditions now. We may want to understand how she's lived her life as a way of understanding how she would like to live her life in the future. We may want to understand today how is it that what her uh, uh, how is her life now and the events of her life affecting her ability to access care and get the care that she needs, and the safety and efficacy of the treatments, and how are those treatments, how are all those care demands affecting the ability to live her life. Because as opposed to a patient in the hospital who comes in with an acute problem and lies in bed, and then hospital staff come in and do things to them, in patients like Maria Luisa with chronic conditions, which are the most common types of patients that we now see in healthcare, it is Maria Luisa who will have to implement the program, but also she'll have to implement the program by weaving its demands in the strands of her own life. But also biography tells us about her goals and priorities for the future. This is about not only biology, but also what matters to Maria Luisa in relation to her biographical story. Otherwise, our responses will be generic. Not only that, but also if we see Maria Luisa and her family not as the reason we all come to work, like Dominique showed in that first set of slides, was the reason people gave for why they came into a career in healthcare. But instead, we see Maria Luisa and her family as a resource for our resource limited environment, as an untapped opportunity to actually transfer work to. Maria Luisa and her family are going to be overwhelmed by those tasks. If we just review some of the tasks that we ask patients today routinely to do, we can see how that might happen. We ask people like Maria Luisa to organize their information when they come to visits, to prioritize their questions, to record the visit, to review its content with family members, to review the medical record for accuracy, to use the portal to transmit data, to self-monitor, self-manage, educate herself, manage her appointments, prescriptions, bill pre-authorizations, the lives, overcome bias, keep informed everyone else, advocate for everyone else and for herself, and also to wait. And as we ask Maria Luisa to wait, we think of her waiting for an appointment, waiting in a waiting room, waiting for the clinician to come into the office, waiting for tests to be or scheduled to be done, for results to come, for interpretation and the next steps to be formulated, and so forth. Where I work, there's also the role of insurance in introducing additional weights with pre-authorizations and billing and all these other things. And so all that weight is pausing Maria Luisa's lives at times are inconvenient and distracting her from what matters to her, and creating a significant burden on her. Um, and then when people cannot do everything we want, of course, we stick labels to them if they cannot show up to an appointment, or if they're not following the treatment program. These are some of the labels that we imply. And when we label someone, and not their situation, but them and their character and their persona, we limit the ability of our colleagues and the rest of the folks that work in healthcare to respond to her problematic situation, but rather prejudice the patient towards perhaps not feeling that they're doing their part in getting better. And when somebody comes for care, and what we respond with is with indifference to their situation, or with attempts to actually limit that care that they receive through this casual labeling, this is fundamentally cruel. And without care, without all these elements that contribute to care, but instead with blur and generic and burdensome treatments that are sometimes cruel, healthcare, the care dissipates from healthcare. Healthcare without care is unsustainable. Not only financially, I think most developed countries are struggling to pay bills related to healthcare, but not only environmentally, with 5 or more percentage points of carbon and greenhouse emissions contributed to by healthcare in the developed world, but also, and more importantly for our conversation, humanly unsustainable. And this is, statistics vary a little bit, but, for the most part, we are finding that over 70% of clinicians, particularly women in primary care, in general practice, are experiencing moral injury. And 40% of clinicians, and varies by specialty and location, but it's around 40% of clinicians have either left or are intending to cut back their hours or leaving clinical practice altogether. This is problematic because, this is the reason, the professional reason, d'etre for these clinicians. It is, and it's also very expensive, both financially and emotionally, for patients and colleagues to see their clinicians leave, and for institutions to retain and recruit new clinicians. When patients and clinicians are together, about 40% of the agenda for their visit is determined by standards, protocols, and measurement data requirements that are independent of who the person is. And so the patient has to push themselves into the agenda for the visit. And when they start saying why they're there, clinicians interrupt those statements within 11 seconds, indicating a significant hurry in that visit, which limits the ability of clinician and patient to focus the visit, perhaps for which they may have been waiting for a long time, focus that visit on what matters to the patient. And from a patient's perspective, particularly if you look at patients with multiple chronic conditions, 40% of them are reporting unsustainable levels of burden of treatment, which basically means that they're about to stop something about their healthcare because they can't implement it in their lives. And that something might be the most important part of their care, but maybe also the most burdensome. So if we go back to this depiction, we can see that with all these pathologies of care, instead of care in healthcare, what we're seeing is it's this industrialization of the care process. Instead of care of each patient, we're processing people through, making sure that we emphasize access, improve value, reduce cost, and enhance throughput. This is not what we sign up to do. This industrial healthcare dehumanizes, makes interactions transactional and devoid of care, and introduces these pathologies that I've been describing for you. So how might we move from this industrial healthcare, which I think, and you would agree, is an undesirable evolution of healthcare globally, to a better situation, one in which our systems and the people in those systems in particular are able to offer careful and kind care for everyone? First step is to think about what we are here for, what we sign up to do, what are these organizations about, and what are the people in them showing up to do. And as Dominique said, we're showing up to care. And we need to make sure that we constantly remind ourselves at every level of our organizations that care is healthcare's core purpose. We must cultivate care in our language and in our culture. When we use language about healthcare challenges, we must use the language of care rather than business jargon that I think obscures the fact that we're talking about people. We must tell stories about care, both of successes and failures in care, so that we can use them to drive higher quality care. We have to cultivate care as a cultural intervention. And this graph, I think, is helpful because a lot of our quality improvement activities have fundamentally focused on the bottom right of this graph, the cure side of this graph, where there is a fix, where there is a right patient, right diagnosis, right cure, correctly deployed at the right time, the first time, with the right expertise and equipment. There is a right answer. I recently had cataract surgery on my left eye because of trauma to that eye a few years back, and I was put on a literal conveyor belt. I sat on the chair moved with me, and I got an IV, and I got looked into, and my surgeon, who had no relationship with myself or with my eyeball for that matter, just took care of the cataract, and I kept going through, and I was discharged. The operation was 15 minutes at tops, 30 minutes from door to door, and I was out. And to have that process be perfect with no defects was essential for me. On the other hand, on my clinical activities, I take care of patients with diabetes and other chronic conditions. There, the challenge is different. There is no right answer. We need to manage symptoms, mitigate adverse effects, cope with disappointing results, which is the most common outcome in chronic condition care, prevent complications, rehabilitate sequela, provide self-management support and problem solving, ultimately make the program of care fit in the life of people. And this is what I normally do. Now, notice that in this graph, even in the place of cure, if you go to the top, there's a small segment of care. If I were to get a complication from that operation, then all of a sudden I would have had to have a relationship with that eye surgeon and work with them to try to rehabilitate my eye from whatever complication may have occurred. Similarly, on the other side of care, there are not often, but there are sometimes opportunities to fix aspects of the patient's health problem. In the case of patients with type 1 diabetes, there might be an opportunity for a pancreas transplant, and there might be an opportunity to go to cure. But in both circumstances, there will be still the need for care. So if healthcare is an institution or is an investment in human flourishing that is based on problem solving, the two ways of solving problems is to fix the problem or to care for the person with the problem as we try to advance their situation. And we want to make sure that we need to be ambidextrous as an organization and as people as we handle the patients that are coming in. When we're thinking about cure, variance is a defect. When we're thinking about care, variance is a virtue. In the left side, on the care side, where variance is a virtue, patients and clinicians, as I was joking at the beginning of this, must dance together, must work together closely to figure out what to do. This is well reflected in this sculpture by Rodin. It shows two hands of two different people coming together, fingertips almost touching, and creating with the palms, creating a space for things to happen between them. This is called the cathedral, and it's that space that actually creates the function of the cathedral, if I may. And Rodin had to chip away at everything that was between those two hands in order for those two hands to come together and form that cathedral. And so that is, if the first task was to cultivate care, the second task is to radically change the conditions in which we care, conditions that allow for these two hands, for these two people to come together and do good work. Work by our colleague Mark Linzer. He was surveying practices in the United States around the time of the pandemic and was finding what the burnout among clinicians was. And that is represented by the brownish middle line that was the average at around 40 to 50% burnout during that period of time. But notice that average actually hides two groups: a group that is, has a burnout rate of about, 7 to 80%, and a group that has a burnout rate of about 20 to 30%. And the group that was more burned out was a group of clinicians who did not feel valued by the leaders, by the organization, who could not control the work conditions in which they were caring for patients, who could not work in teams, and had to work in environments that were hurried, where they could not make time to see their patients, and chaotic and disorganized. And so the work conditions are important if we are interested in clinicians being available, being able to be present to respond to patient situations in ways that reflect what matters to them. For that, we need clinicians who are well and who are competent, so that they're doing more good than harm. We need to be able to create the teams that enable the collaboration, but not only for them to be more competent, but also so they can take care of each other. And when we bring new technologies into their workspace, be it the electronic medical record or artificial intelligence or whatnot, we need to make sure that when we bring those things, we do not only a financial impact analysis, but what is the analysis on the ability of these clinicians to care for their patients. This is an example of one such technology. Took a picture of the floor of where I work, and in the 1950s, somebody chose to put cork on the floor right outside the clinical offices. And I think it's a demonstration of a profound respect for what was happening inside those clinical offices, to reduce the noise that was coming from the corridors, to introduce thick walls and thick doors, and to make sure that inside those offices, there are no distractions that will prevent people from focusing on each other. And then, of course, over the years, the introduction of technology like the computer screen on that semicircular table to share with patients images or information or bring together tools for shared decision making are things that demonstrate an investment in care. And then we have to work directly on these pathologies of care and move from blur to high definition, from burden to minimally disruptive care, from hurried to unhurried conversations, and from the cruelty of indifference to responsiveness. And here are some examples of how might we do that. To see patients in high definition in their biology and their biography, it is important to ask, and preaching to the choir here, what matters to you? To be curious about patients' lives and to find ways of bringing that forward in the places where we look, for instance, the electronic health records. To move towards minimally disruptive care, we need to make sure that we don't keep transferring work to patients and their families, that we seek to understand when people cannot show to appointments or when they exhibit low fidelity to our treatment programs, what's going on that perhaps is too burdensome or has an excessive demand on patients' capacity. We need to simplify care. Some people might be excited about lean and sigma and these sort of things, but when they look at lean, they focus only on the lean production. How do we reduce waste for the healthcare organization? But sometimes we transfer that waste to patients and families. So we also have to do lean consumption. So how do we make sure that patients and families don't have to experience a lot of waste when they're accessing and using our services? And we need to promote patient capacity, their resilience, their literacy, their financial, their physical and mental health and quality of life, and to support in some way their social capacity, particularly among people who are lonely. To promote unhurried conversations, we need to make sure that we limit interruptions and distractions, both from personnel, but also from our electronic environment. We need to make sure that we schedule appointments in a way that is responsive to who are the parties that are coming in and what is the purpose of their meeting. Most places just simply allocate the same amount of time to everybody, which is not something we even do for our business meetings. And we need to implement continuity of care, which saves a lot of time. It furthers the relationships. It prevents the need for unnecessary diagnostics when people don't know what's going on with this particular person. It prevents patients from becoming re-traumatized when they have to tell their story to a new clinician every time. And it's associated with reduced mortality. And finally, in terms of responsive, we need to make sure that we eliminate the wrong doors, the computer says no aspect of our systems, that we need to make navigation easy so people can find the care that they need from the first point of contact with any of our services all the way through. So Dominique, back to you.
I hope what Victor has shown you is really reconnecting us back with our core purpose in healthcare, which is care, and some of the diagnosis and the treatment we think needs to happen. And we'll describe a bit later on some places where you can find many more examples of the things that you might be able to be thinking about doing in terms of tackling that. And many of you are, and particularly the What Matters to You work feels really important. I would love to see a medical record where instead of having people's biometric data and statistics and medical results, it started with the biography of that patient. So hopefully we might aspire to that at some point in our work. Okay, next slide, please, Victor. So many of you will know this story about previous US President JF Kennedy, who went to visit NASA and had a conversation with the janitor in the corridor asking what his role was. And he said, you know, my mission, I'm here to put a man on the moon. And I think that we've not managed to create that same context in healthcare. If you go around asking people in their roles what they're there to do, you'll hear the same answers about putting people into the discharge lounge rather than to help heal, treat, care, improve lives and health. But yet we, Victor and I, believe, and many of you on the call, I'm sure, believe there is no more important and no more powerful mission than health and care. And so we feel optimistic and positive that we really can get to our mission and purpose and bring that back into the workplace when it sometimes feels like it's a bit lost. So holding on to that feels really important. And I'm going to pivot a little bit now. So we've talked a bit about mission, purpose and meaning. I'm going to pivot in a moment to a piece around kind and kindness, which Claire just talked about, but I think I've got one more slide before I do that. So just to segue now into another group of colleagues who've been doing some fantastic work and thinking on the role of kindness in healthcare and realizing that many of our conversations have a starting point of money or efficiency. And of course, those things are important, particularly with a quality lens on, but actually talking about kindness is a really important part of healthcare and an underrated currency. It enables us to do so many things, and it's particularly important in many spaces of what we're trying to tackle around things like equity or patient safety. And so this was one of the starting points for me, reading this paper from some colleagues as a way sort of into the thinking about kindness. Next slide, please. And I really like this quote because I think it sums up some of the skepticism I had about kindness, which is it feels really important to do it, but these sort of random acts of kindness, not trying to take away from the things like, oh, give a colleague a Kit Kat when they look like they're feeling down. Those things are, of course, really important, but rather than making these things just random acts, making this the norm and the culture. And we don't talk about random acts of gym going as a key to a healthy lifestyle. So perhaps not the way to embed kindness and some of the things that Victor's also been talking about. And if you haven't come across Kaleidoscope, they're a fantastic social enterprise. This is their leader talking about kindness, and they've got a whole bunch of projects and programs and work on kindness in healthcare, including some work that they did with Victor and others, which I'll talk a little bit more about towards the end. But they also have some interesting ways that they think about kindness that run through all of their work, including how they recruit staff, how they remunerate staff, and how they want the culture in their organisation to be. So kindness is really important. We need to think about it as a consistent thing that we do rather than just randomly dropping it in. So how do we make this kind of stuff more systematic in our work? A really good book to pick up, a really thin read, is by someone called a great guy called John Ballot, who worked with colleagues Penny Campling and others on a book called Intelligent Kindness. And this is the second version. So for any of you who've got the earlier book, the front cover looks a bit different. But John's starting point and premise is that we need to start from a place of kinship, which means really thinking about people, staff, patients, wider community from the perspective that they are our kin. And that's the root of the word kindness, kin, thinking about these people as if they were our relations or our family members. And if we do that, for many of us, the transactions and the interactions that we might have start to feel a little bit different. And what his theory is that if you start to approach your work with a perspective of kinship, it promotes greater kindness, unless you, of course, have fallen out with all of your family, in which case I don't advise it. But generally, people value and love their family. And if you treat other people as if they were your family, that starts to promote more kindness, which then directs a level of attentiveness to them that you wouldn't necessarily have, which then enables you to be more attuned to them and builds trust. And this develops what's really crucial and a big bedrock of some of the work Victor was talking about before, a greater therapeutic alliance. And that can be either in a clinical encounter or indeed a non-clinical conversation or between two colleagues. And that leads to better outcomes of all different types. And there's lots of evidence on that. So one of the first ways into promoting more kindness in our workplaces and in our work is starting to take that lens of kin and kinship. So that's one framework or model that I'm going to share with you. Next slide, please. The second one is some work that a very dear colleague and friend of both Victor and ours called Len Berry developed. Len's a professor of management, and he's done a lot of studying of the role of kindness in healthcare, and he is a brilliant guru of this stuff. And what he did was look at the role of kindness in cancer care and codified some of the behaviours that we characterise with kindness. So it's not just about being nice, and indeed there's a whole debate about is kind the same as nice, and many people will argue it's not. There's a fantastic book on radical candour which is really amazing, but I segue off back to kindness and some of the codified behaviours. So Len describes 6 of these with colleagues that have been evidenced and proven to lead to better outcomes for patients with cancer and now more widely. And they include things like deep listening. So really, how often when you've got an interaction with someone, do you deeply listen to them without distraction? And that comes back to what Victor said about the unhurried conversation. That doesn't necessarily mean more time. And indeed, Victor and colleagues have showed across a period of time that this doesn't require additional time spent with people over and above what might have been, but it requires quality time. And I know I'm very guilty of being on the phone to someone like my mum and undoing the dishwasher at the same time. So how do we have deep listening? Clear empathy, generous acts beyond what people would expect. So going that extra mile, the timely care that reduces stress and anxiety. So that picking up the phone to someone to say, I've acknowledged that you've sent me this or done this, and I just want to give you some really quick feedback, or I'm just calling from the operating theatre to tell you things went well. I'll be back up later, but this is just a quick call to check in with you. So many of these things feel intuitive, but really codified to show that they make a difference. Gentle honesty, and I just talked about that. Radical candour is really important, and then thoughtful support. And so this paper reference there gives loads of examples, and I urge you to think about these 6 areas and potentially think about where you are doing more work in or paying more attention, and thinking about where maybe you need to spend more time. And of course, no one's going to be 10 out of 10 across all of that. So next slide, please. So we've done kinship and intelligent kindness by John Ballard. We've done the work by Len Berry codifying some of the behaviours around kindness. This is some fantastic work by Michael West and others, and Michael's done a lot of work on compassionate leadership, another sort of cousin related to kindness. And of course, both kindness and compassion are different, and there's lots of different definitions. The one I like really is about kindness being an action in response and a desire to sort of help others flourish. Whereas compassion often starts from the perspective of trying to alleviate suffering from people. But you can see that they have common pro-social concepts with them. And Michael has codified what compassionate leadership looks like around attending, paying attention. He calls this phrase listening with fascination, which is this real deep listening, a shared understanding of what people face and being able to have empathy, and taking intelligent action. So you can see a big overlap with the behaviours we're talking about around kindness, and loads of evidence to show that if you adopt these types of behaviours in your leadership, that your colleagues will be happier and your outcomes will be better. Huge organisational studies have shown the benefits of this. And Michael's got a great framework about compassionate leadership that you can find out more about through a number of different places. But onto my final framework, I feel like I'm doing us a bit of a school run here with a blackboard, but the final one, a really fantastic set of work built on by a number of people, but the way into the importance of psychological safety that I learnt about was through Project Aristotle, developed by Google, big multinational company that clearly had some important drivers around wanting to make their teams work really effectively, both about being the best in the market, but of course with a profit lens on it. But the work they did is very transferable to many of us in all of our settings. And what they did was look at the characteristics that make up the most high performing teams. And they had things like making sure that people have really strong clarity and structure about what they're doing, having meaning in their work. So that links back to that mission and purpose piece. What are we here for? Being able to see the impact of your work. So for those of us particularly who are not close to the bedside or the patient care, how do we make sure that we see those impacts? If you're sitting in a finance role or something, how much are you getting out there and going and seeing the impact of the work that you're doing? And being able to depend on people. So people doing what they said they would. Those were proven to be really important. But the thing that knocked all of those completely out the park was psychological safety, this concept of being able to bring your whole self to work, to be free to speak up, to speak truth to power, to speak out about things and feel safe in a psychological way. And there's a fantastic author that many of you will know about called Amy Edmondson, who wrote this book on fearless organizations. The link to kindness is really strong and clear. And I was lucky enough to present with Amy at one of the IHI BMJ international forums, and she talked about this virtual circle between kindness and psychological safety as one leading to the other, and one being a foundation of the other, and one being a product of the other. So having more kindness around leads to greater psychological safety and vice versa. So 4 areas where I think we can really promote kindness through the things that we're doing in our leadership roles with our teams and in our day-to-day practice and work. And so just back to that mission and purpose piece as well, I always giggle when I see this terribly sad piece of art picture here, which is about slicing up the tennis balls, and you can get more in the tube and it becomes very efficient, but we lose the ability to do the things that we started out to do. So don't forget your purpose, be efficient and be productive, but don't forget why you're here. So just the last couple of things to wrap up before we potentially take some comments and questions. This is a mini, I guess, a bit of a theory of change that based on some of the things that Victor and I just talked about, the clarity of mission, why we're here to bring care into healthcare, thinking about our purpose and meaning in work. And then thinking about, on the other side of that, some of the bits that I've just talked about around kindness, around compassion, around empathy, and how we have really strong evidence base to show that all of those things are better for patients and better for our teams and better for the population and our organisations. So if you ever needed any evidence, here is a bit of a compendium of that when you're trying to convince others, especially when it feels difficult out there, but also some very practical examples going on out there in the world. And I'm just going to share with you a few places where you can find out more. So Victor and I both met through our shared interest in this, and I joined the Patient Revolution, an organisation that Victor co-founded with this mission to work together to change the conditions of care. And I was originally a fellow and now work very closely with Victor on the board. It's a place where you can find lots of great, fantastic information and examples in our library about people who are creating mini revolutions. We'll put the link up in a second on a different slide. Next slide, please. There's, of course, amazing movements that are going on with fantastic focus on this kind of bringing humanity back into healthcare. So the What Matters to You movement is something that I'm calling out all the time and thinking about how we do that in all of our conversations in our workplace, and try not to have a conversation with someone I'm meeting for the first time, whether it's a patient or a staff member, without talking about this stuff. But plenty of more system level work going on related to this, as many of you will be involved in and know. And then a really nice a group of people who meet once a month around a conversation for kindness that was started really with a bunch of us talking about this stuff and saying it's really important, and how do we keep spending time focusing on it and thinking, what does it mean to be kind in the way that we, for example, regulate healthcare or train our health professionals, and have invited lots of expert speakers in to come and talk to us around that. So there's now over 1,000 people in this movement across a whole bunch of different time zones and countries that meet once a month on a Thursday. So if you're interested in that, you can always get in touch as well. And then I'll hand over to Victor, who will tell you a little bit about the patient revolution very briefly, and then help finish us off in terms of this presentation in the last minute or so.
Yeah, Patient Revolution, and the link is there on the bottom left, is an organization of care activists around the world. And they're trying to do that shift from industrialized healthcare, careful and kind care, through local and immediate action, which we call mini revolts or mini revolutions. And the organization provides these activists with a community that is a place for drawing courage and support, and from learning from each other. In terms of learning, we also have the school, where we have a series of free courses in relation to learning about care and also change that facilitates this work. And we have a greenhouse where there are ideas and policy ideas and tools that can be used to advance careful and kind care. And of course, one of those ideas is this book. I don't get any money from it. All goes to the organization, but tries to summarize some of the concepts that we've discussed today. It's called Why We Revolt, a Patient Revolution for Careful and Kind Care, with the organization providing organizational and moral backbone to this global movement for care. It's a global movement that reminds us that to care is fundamentally human. Organizations cannot care, technology cannot care, AI cannot care. It's only people that can care. Every one of this on this call is here because somebody chose to care for and about you at some point in your life. That mission is infinite, but our capacity to do it is not. But we have to remember that when patients get the care that fits in their lives, both within the healthcare system and at home, they're able to flourish. That is the reason for careful and kind care, is that smile. What are we willing to do to have our patients smile like Maria Luisa is smiling in front of that massive fish? And I think this is when we recall that care is not only exhausting, but when under the right conditions, care can also be a renewable resource. That smile refueling our commitment and our purpose to care for people. So what will you do differently tomorrow? And that is the question that we will leave you with. And we hope that the answer will be to relentlessly work towards careful and kind care for everyone.